So that's my look in my axial sections. And for my coronal sections, let's see if I can move this anteriorly. There we go. So I usually start at the anterior aspect of the patient with my coronal sections, and I divide it up into thirds as well. So when I go from front to back, I'm going to look at the most superior aspect, and typically I'm going to look at my sinuses. If we have it, we'll look at the orbits, the nasal fossa, that sort of thing. So I'm just looking at my more superior structures. I'm not even looking at the maxillary dentition at this point. I'm just going to make sure that my cortical borders are nicely intact. Of course, we can see our nice incisive canal right there. Moving back, I want to make sure cortical borders, we already talked about tooth number 14. I'm making sure the palate is nice and intact. Lateral aspect of the nasal fossa, maxillary sinuses. And all the way back, oh, cute little third molars, but making sure everything looks good. And we have our medial and our lateral pterygoid plates. You can see that right here very nicely, medial and lateral, and all the way back. All right, then I'm going to come forward. And at this point, if it was a larger field of view, I'd pick up on my cervical spine. At this point, since we don't have that, I'm going to look for my mandible, and I'm going to go down through the mandible. So just coming anteriorly, and I'm looking again, making sure that our cortical borders are nice and smooth and intact. Everything looks good. Check out the teeth a little bit as we go along here, but definitely making sure these cortical borders are nice and intact. And all the way to the anterior mandible, where we know we have a little situation there. And then I'm going to do one pass back, just looking at my maxillary dentition, and making sure that everything looks pretty good from there. Let's see. Oh. Definitely have an issue with this tooth right here as well. See a little periapical lesion there, and all the way back. And so at that point, I'm done with my coronal sections, and I'm going to pick up going through my sagittal. I always pull the crosshairs over to the right-hand side.
Okay.
And then typically with this, I'm going to go ahead and, with any of these, I usually enlarge this, but definitely want to take a peek. Let's see if we can make it go down through. Actually, oh, okay.
You could also drag in between the windows to make one window.
Can I?
Yeah.
This is awesome. Okay, so I did that one. Can I drag up here?
Yeah, yes you can.
Oh, so okay. Okay, I'm gonna have to try to make myself symmetrical here. OCD kicked in.
Yeah, I could see that.
All right. Yeah. All right. So that's really cool, because then you can enlarge this. You can be reviewing it while you're, you can see exactly where you're at. All right. So let's come down through here, and I'm looking at my periodontal ligament spaces. This is great. The sagittal is great for looking at your periodontal ligament spaces. You see it really nicely and see what's going on with each of the teeth. Obviously, our issue here may be interesting. Yeah, you can see that root apex right there as well. So definitely wanting to see if we have any type of root resorption with that particular lesion. That's really nice. And all the way to the left-hand side. All right, perfect. You can barely catch those little condyles, just a little bit, but all right. And then I'm going to go from the left side to the right side, looking at the maxillary dentition. So, and the relationship of that third molar to the distal aspect of number 15. Want to make sure there's no root resorption. Obviously, we can see 14. We have a nice periapical lesion with most likely an associated mucositis. And see all the way around, but definitely making sure that everything looks good. I'll come back to that. Okay. And yeah, our premolar looks like we've got a little apical lesion going on there as well. So our mucositis on this side, it's kind of interesting. So we do have, I would say we do have mucosal thickening that may not be odontogenic in origin, but we do have some that may be odontogenic in origin. So what I usually typically will say is that we have an acute or allergic rhinosinusitis in conjunction with an odontogenic source. Because we can see that it's starting to kind of crawl up the sides of the sinus.
Okay.
So if it's crawling up the sides of the sinus, most likely it's not just odontogenic in origin.
Okay.
They're kind of both. But yeah, so that's what I would say for that. And again, over to that right hand side of the maxilla. And then I typically do one swing through just looking at the midline structures. So I want to make sure that my incisive canal looks pretty good, nice straight. Canal, we don't have anything in here that looks like we have a cystic process. When I'm looking at it in the larger views, which I don't know if you have the larger views as well, but we would look at cervical spine, sella turcica, and that sort of thing. Okay. So making sure those midline structures look good. And then we're done.
Wow. So yeah. For the report, you write all this out? Is that what's to be expected from a report?
I usually, anything that I've talked about, I'll go ahead and write out. Definitely we would come down and spend some time with this little lesion down here.
Would you measure that usually?
Yeah, I'm going to measure that. I want to discuss it. Hold on, let me see if I can move. Can I make, is it like an automatic to make them go back to normal?
Yeah, there's a, let me go ahead and do that. It's up on the, it's on the right side, and it's that skull with the arrow. Keep going to the right. There you go. Click on that, reset, or it should have reset. Oh, it's reset all the views.
Okay.
I think there's a. Oops. Here, let me go back. Hey,
playing with it.
it's the beauty of having software you've never used before. I think it was this one.
Oh man, did I kill it? Okay.
I forgot which case it was. I don't know. Where was that?
One that has like, he has like a simple bone cyst or an odontogenic keratocyst.
I think this might be it. I'm not sure.
Yes, I think that is it.
Okay. Yes, we're back to normal.
Sorry. Okay, I can't go and play with buttons.
let me give you control. I'll give you control. Okay. I think you have.
Let's not get control anymore. No control for you.
It's all yours right now, it looks like.
Okay. Yeah, so we come back down and look at this and make sure it's, what it's doing with the teeth.
Okay.
Let me go ahead and I can pop this guy up in the corner. Does this one?
Yeah, let me do that.
Okay.
I just rotated that. I'm messing with the software altogether now. All right.
It's super easy software, though.
It is. This makes it extremely large. And then when I click in here, I have this view here as well to maximize it for each window, and that's where the little square went.
That's where I was looking for. Okay. So yeah, so we can see it's well defined. Let me scroll back.
What's well defined when you say that? The border of the lesion?
The border is well defined, but it's not necessarily corticated all the way around. So you see that lesion really well. So when it's well defined, it means that you have diseased tissue right next to the healthy tissue.
Okay.
And so it means it's something that the body has been able to wall off, which is a good thing. It tells us that it's slow growing. The body's had time to wall that off. Mm-hmm. And most likely it's a benign entity.
Okay.
Now, it's not necessarily corticated. I would say that it has kind of a delicate margin, or we might say it's partially corticated. We like the word partial because then you're kind of hedging a little bit.
Yeah.
But you can kind of see that. So what does that mean when it's corticated? That means that the body has walled that off, and you get like this white line around it. Okay. That means it's corticated, it's walled off. But this has actually a nice delicate margin to it. So not necessarily that thick cortical border we would see with a cyst. So it might tell us we have something else going on there. And then we want to look at the teeth, So of course we definitely have 26 and 27 that are in it, but we don't have any root resorption. So root resorption is important because it lets us know what kind of lesion it is again. So for instance, ameloblastoma likes to cause root resorption, where something like a simple bone cyst or a odontogenic keratocyst will not.
Okay.
And this looks like, obviously we had our third molars. So this is a younger patient. My number one with a lesion such as this, so what did we say? It was well-defined, partially corticated, but you have kind of those delicate margins to it. We do have thinning of that buccal cortical border, but it's intact. And it does look like it's scalloping a little bit. So you see some scalloping, kind of scallops up between the teeth. And the internal content, of course, it looks completely hypodense or radiolucent. With our CBCTs, we tend to talk about it in terms of density. And so we'd say it's hypodense inside. So my number one for this would be a simple bone cyst, which is also known as an idiopathic bone cavity. And those are essentially empty spaces. So when the surgeon comes in, he's going to know immediately what it is because it's going to be an empty space. And once he kind of scrapes on the bone and it starts bleeding, it's going to go ahead and fill in with bone and essentially heal it. So I always say, if you're going to have a lesion, this is the one you want to have.
Okay.
Because it's not epithelial lined. It's really more of a pseudocyst. So when I went to school, they called it either a traumatic bone cyst or a simple bone cyst. And now they call it an idiopathic bone cavity. Early on, they thought it might have something to do with trauma, but there was no association with that. So they kind of dropped that.
Okay.
So really, idiopathic bone cavity. So that would be our number one in this particular age group. And our number two would be an odontogenic keratocyst. So those would be our differential, and we would go ahead and recommend a biopsy. But again, the surgeon's going to know immediately once he gets into that which one it is.
Okay.
But my bet for this age group would be our simple bone cyst or idiopathic bone cavity.
Okay.
Yeah. So we'd go ahead and write that up. We would write up any of the teeth that we saw, the periapical lesions. I do some custom sections with my software, and so especially with the teeth, I'll split out your mesial buccal roots, your distal buccal, and your palatal roots, so you can see the lesions at the apices of each one and the relationship to the inferior aspect of the maxillary sinus.
Okay. Now, if somebody turns in, first of all, how easy is it to get a DICOM to you? Is that the format you would want?
Yeah.
And how does that work? If we go to your website, if a doctor goes to your website and they have a case in mind, what do they have to do to get a case to you?
So they do need to make an account with us, and then they can start submitting cases. There is an online referral form, so they can tell us exactly what it is they're looking at. Please tell us what you're looking at. So many times we get completely empty ones, and it's a fun Easter egg hunt, and we enjoy that too. We always look at everything. It's a complete pathological overread. But if you tell us what you're interested in, that helps us kind of be able to focus that particular report to what your concerns are. And then we'll still go ahead and put everything else down, but we can kind of tailor that a little bit better for you.
Okay.
And so they'll fill that out, and then they just kind of move along, hit the next button, and it goes to where you can import a DICOM. And you can either drag or drop it right onto the website, or you can use the browse feature and find wherever that folder is on your desktop. So you would want to, based on whatever software you have, you would want to go ahead and export that out somewhere to your desktop perhaps. Okay. And then you can easily upload that to our website. And then, the next part is just paying for it, and then it gets submitted. Now, we actually can't see it in our lineup. We have it set up so that it drops in once it is paid for and that submission's completed, and then it drops into one of our queues.
Okay. So, and what's the turnaround time to get a report?
It's about a week.
A week.
So
okay.
about 5 business days is what we aim for. And then we do have an ASAP option as well. So if you're like, wow, there's a big lesion, I'm really concerned about it, or maybe the patient has a history of cancer or something like that, and they're very concerned, there's an additional fee, but you can do an ASAP, and you'll get that in 1 to 2 days.
Wow. Okay.
Sometimes same day. So
great.
Yeah.
Well, it's a great service. I talk about it all the time.
Awesome.
So because I know you, I know who you are, and I know what kind of work you do. You're very thorough.
Thank you.
It's not just a general report. You go deep into it, and I've seen it. So
thank you. Yeah, we do. We want to add additional things onto the report. Sometimes you're reading a radiology report and you're like, I have no idea what they said. And so, if we say, oh, there's an anostosis. Well, what is an anostosis? Go ahead and put that additional information in. So it makes it really easy for the doctor to just look like a massive hero when he's handing this to the patient. So the patient says, oh, I don't know what that is. And even if you don't know what that is, it's spelled out easily right for you, so it makes it super simple to know what everything is. And then we give some, management options as well, especially if it's a particular lesion. We'll discuss, the features of that lesion and what the patient can expect as far as management for that.
Okay.
Yeah.
What is the best way to contact you if they have any questions about the reports? Is it through your website? Or is there an email?
We actually have a feature through the website where you can text back and forth with us within that case submission. So it's all HIPAA compliant. It's all within that patient case. They can text back and forth. So you can actually type in these little boxes that say, comments for the radiologist or that sort of thing. But there's also an email contact through the website, which comes right to me. And on our reports, we'll also go ahead and put down our phone number and our email so that if you didn't want to use the in-website chat service, you could email us directly or call us directly. So for whoever has read the CBCT.
Okay.
So I do work with a group, and I know how everybody was trained. Everybody's from UNC Chapel Hill, and everybody has extensive years of reviewing CBCTs and education. And for instance, my program director from UNC Chapel Hill retired and came to join me, and he is an amazing individual that has done the dosimetry for almost every CBCT that's on the market.
Okay.
And he's still working on that kind of stuff. So yeah, I have a great team that works with me.
That's great. What is the website once again?
It's www.dentalradiologydiagnostics.com. And then, of course, we do have our educational one that I'm super excited about, and that's www.drdxdocs.com.
Great.
So,
well,
yeah.
Thank you for all the information. It was a lot. Very, very informative, so I appreciate it. It's good to see you again.
Thank you for letting me play with the your software, and that's a great case. That's a really fun case.
Fun for you. Awesome. Radiologists.
Okay. That's the thick and twisted world of a radiologist. Yeah, we always get excited to see these things. I know it's not, we feel bad for the patient, of course.
Sure.
But it's really cool to get to see interesting things. And as a geeky radiologist, it's like, wow, that was so awesome.
Yeah.
But yeah.
I always learn a lot from you, so thanks for your time. I appreciate it.
Well, thank you. I appreciate it. It's so fun to get to see you.
I know. We need to do more things together for sure. So we'll figure it out.
Yeah. And nice, well, I guess it's tea, but
water.
Coffee and CBCT. Water.
Water or tea and CBCT. It works. All right. Well, have a great day. Thank you again.
Thank you. Bye.
Bye.